So, defibrillator. So, here's a question for you. It tells us to apply the pads according to the pictures. Remember that talk to me on here? Oh, first of all, before we leave that subject, why does it say stand clear when it's analyzing? Yeah, if I'm touching the patient, does the machine know whether it's his electricity or mine? It doesn't know. It doesn't know. So it can say normal sinus rhythm, no shock advised, do CPR. Well, maybe that's not what this guy had. He might have been in ventricular fibrillation all along. And so the second time that it told us to stand clear was when? When I'm going to shock. Because remember, the shock is designed to stop the heart, and if I'm touching the patient, I might get part of that shock. And so my heart might get stopped. All right, so it tells me attach the electrodes according to the pictures. Well, there's pictures on here, and there's also pictures on the electrodes themselves telling you where they're supposed to be placed. What happens if in the heat of the battle and all this adrenaline's flowing, I get them switched around? Is it going to work?
I assume it will.
Yes. It will. Normally, if we've got them in the right position, the patch that's way up here on the upper right-hand side, that sends out the initial signal looking for the other patch. This is a biphasic, they call it. So if it finds the other patch, then it shoots the current across to the other patch, and the heart is in the middle. Well, now, if I get them reversed, this is still the patch that's going to send out the signal. It's going to look for the other patch, but now it finds it up here. Well, it's still going to send out a shock, but it's going to go from the bottom up to the top. It's still going to hit the heart, so it's still going to work. Same thing as if I put a patch over the front and over the back. If it finds the other patch, it's going to send the shock, so it'll still work. Earlier, you had asked about somebody that's wet environment, right? Yeah. Let's say it's out at the pool. The fellow is in doing laps. And he gets out of the pool, he walks across the deck and collapses. Soaking wet, got a swimsuit on. Can I use the defibrillator? Yes. Yes, you can. When it was a monophasic, it would have been a real problem. With a biphasic, because it's looking for the other patch, the amount of water doesn't really matter. Here's what matters. I have to be able to stick that patch to bare skin. So I've got to wipe that dry so that that patch will stick on there. So yes, I've got to dry him off, but only where I'm sticking the patches. I don't have to wipe down the rest of his body. I don't have to pull his wet swimsuit off. All I have to do is wipe down the areas where I want the electrodes to attach to the bare skin. All right? Which brings up another subject. The first thing it told me was to remove the clothing, did it not? Yeah. Okay. So now I remove the clothing, or not. There's no buttons on here. There's no zipper on here. I got a problem. How do I get this off? I can't tear it. Well, if I go to my handy dandy case that's in there, there's a pair of paramedic shears. They're serrated, so it'll grab the cloth, grab the fabric, and it'll cut. So I open up the shirt or the blouse, and I pull this back, and oh my goodness, there's Yogi Bear staring me in the face. There's fur everywhere. And it might be a man or a woman. Either one. So I got a problem, because I need to attach this to bare skin. Well, in this handy dandy bag, we have a safety razor. And the same thing that's in there. There's a safety razor. So I can shave this off where there's a whole bunch of hair. I can shave it down. And students have asked me, do I have to lather them up first? No, they're dead. okay? And they really don't care, all right? So I have to shave them off, get down to bare skin. Now, when I pull this back, I look on this patient's chest, and there's something attached to his chest or on the ribs, or it looks like some sort of a medication patch. What kind of medication might be on a patch? Any ideas? Nitro, what's that used for?
Blowing things up.
When what?
Blowing things up.
Correct. Nitroglycerin, which, as Brian said, is an explosive, but in medicine, it can be used for people that have something called angina. That's chest pain. Well, they usually get chest pain because their arteries are starting to clog up with plaque and cholesterol. And so the doctor will prescribe nitroglycerin because it dilates the blood vessels. It opens them up, makes it easier for the blood to run through. So here's this pain patch, this nitroglycerin or this pain patch, or even a nicotine patch, could be a hormone patch for birth control or whatever. There's all kinds of different patches. I don't know what they are. All I know is that they don't belong on there because it might be an explosive, right? It might be nitroglycerin that can explode. But nitroglycerin dilates the blood vessels. So I go ripping these patches off, and I'm preparing the patient. The next thing I get, really lightheaded and woozy. Why?
You got those in your bloodstream.
The nitroglycerin just entered my bloodstream, dilated my blood vessels, and dropped my blood pressure. So, not a good idea to touch these patches with your hands. So guess what else is in our Jim Dandy case? We got some gloves. So we put the gloves on, then we can tear all the patches off, and it's not going to bother us at all. Okay, so that case is quite important. You've got a face mask, scissors, a safety razor, and gloves. So that's an important part of that defibrillator system. Okay, so I get rid of these patches, and then the machine told me to attach according to what the pictures say. Now here's a question for you. Let's say that this person drops out there in the parking lot and they're right over top of a storm drain. That's a metal storm drain, and they're laying on top of this. Can I use that defibrillator? Yeah, because remember, it's a biphasic and it's looking for the other patch. It's not looking for a storm drain. It's looking for the other patch. And so, yes, I can use it for that. How about if somebody was unconscious because they got hit by lightning? They're out on the golf course, and they get smacked by lightning, and now they're unconscious and they're not breathing. Can I use the defibrillator?
I would say yeah.
Sure I can. Because what's the two criteria? They're not breathing. They're not responsive, and they're not breathing normally. Doesn't matter what the cause was. Yes, I can use that even if they were struck by lightning. Okay? It might have put them into ventricular fibrillation just because of the lightning strike. So I can use the defibrillator on that. So I can use this defibrillator in almost all circumstances. People ask me, well, can I use, well, obviously the pacemaker's not working, right? Otherwise he wouldn't be unresponsive. The pacemaker would take over, or the internal defibrillator. There are people that have both, and there are people that have one or the other. You can have a pacemaker and an internal defibrillator in one unit. Okay? Yes? Yeah. I did see it, actually watch somebody, this happen. They didn't shave him. And they put the patch on there and they shocked him, and all of a sudden you just saw a whole bunch of smoke coming up.
Next time it'll work better then.
Oh yeah. They didn't need the razor the second time. Anyway, so yeah, you can use this defibrillator. It'll tell you when you can't. If you don't have the patches on properly, it won't proceed. So it's pretty much foolproof. So, I'm going to move on real quick to one other situation, and that is what happens if we come to a patient, we check them and they're not responsive, And we call 911 because it's an emergency. And then I check for their breathing, and I find out that they're breathing normally. Do I do CPR?
No.
Why not?
They wouldn't breathe if they don't have blood.
Correct. Now, one of the things I told you earlier is that when we're unresponsive, we're unconscious, our muscles relax. And if we're laying on our back, where's our tongue go? Where's the back of our throat? Okay? So now here's a patient laying on his back. He's unresponsive, so his tongue is relaxed. It's laying towards the back of his throat, but yet he's breathing. So I can help him by getting his tongue out of the way. And I can do that easily by just rolling him on his side. It's called a recovery position. So if I come upon a patient who's not responsive but is breathing, I can help them by just turning them on their side. Likewise, when my patient who gets a shock, when he starts to respond, I can immediately turn him on his side and put him in a recovery position. What does that do? Well, number one, it pulls the tongue away from the back of the throat, so it makes it easier to get the air in and out. Secondly, and this is probably more important, any fluids that are accumulating in their mouth are now coming out onto the ground or onto the floor. So if they're vomiting, if they've got blood, or even an accumulation of saliva, they're not sucking that down into their lungs. Now it's just coming out and leaking out onto the ground. And so that's going to help our patient. And we can monitor their breathing while we've got them up on their side. So in order to do that, what I want to do is I want to take the arm that's closest to me, and I want to extend that straight over their head like this. Then I want to reach across their body to their other arm, farthest away from me, and I want to lay it across their chest like this. And now I grab a hold of their shoulder farthest away from me, and I grab a hold of their knee, and I roll them as a unit this way. I always pull the patient towards me. I don't roll them away from me because I don't have as much control. So I always pull them towards me. And now when I get them up on their side, the arm that was laying across their chest is now making contact with the floor, and their knee that I pulled on is bent and it's touching the floor, and it keeps them from rolling all the way over onto their face. And now, when they're in this position, I can simply monitor their breathing and make sure I see their chest moving. What happens if they stop breathing? Back into CPR mode. Okay. We used to have two positions for opening up the airway because we had concerns about trauma, spinal trauma, and we used to have to do what they called a headlock, a jaw thrust maneuver. They've eliminated all that. They said the risk is so minimal they don't even count it anymore. So the big thing is when you log roll them, you want to do it as a unit instead of pulling the top part and then pulling the bottom part, because now you're twisting the body this way. And so you want to eliminate that by pulling them as a unit. But as far as the neck is concerned, they don't even consider it anymore. But I know where you're coming from because we taught it for 15 years. Yep. If you go to the books, you'll not find this, okay? But let me give you, again, anatomy and physiology. We have veins returning blood to our heart, and it always comes in on the right-hand side. So we have the vena cava, the inferior vena cava and the superior vena cava, and they always enter to the right-hand side of the heart to feed the right ventricle, and so, or right atrium. And so these veins, if you remember way back at the beginning, I said that veins are not under pressure, but arteries are under pressure. So if I put pressure on a vein, it will collapse. You can collapse it. And so when I roll the patient on the right-hand side, where do his organs move to? They move to the right-hand side. Gravity pulls them down. That's the same side that the vena cava is on the right-hand side. So if I roll the patient to the right, organs shift to the right, and they lay on top of the vena cava. Now, it's not a real problem for most people, but think about, like, if I have a fetus in there. Now I've got the weight of the fetus laying on the vena cava. And so it makes it harder for the blood to return to the heart because there's pressure on that vena cava. So the best thing to do, if you have the option, is roll them on the left side. That way all the more organs move away from the vena cava, takes all of the pressure off the vena cava, and you get free blood flow back to the heart. Does that make sense? So if you have an option, and you don't always, but if you have an option, move them onto their left side, and that way you keep that vena cava opened up. I'm going to run through choking real quick. I've got an adult patient at a restaurant, they're choking, and you run over, and what's the first thing you want to do with them? Yes, ask them for permission. Do you want me to help you? And they nod. Their eyes are this big around because they're panicking. And what you want to do is the first thing you want to do is check and find out, do I hear any noises? Because if I hear noises coming from this guy, he's moving some sort of air. It might be wheezes, but if I hear he's moving air, at that point what you want to do is just ask him to cough as hard as he can. Since he can get some air in, cough as hard as he can, see if he can bring that object up on his own. If he cannot bring it up on his own, or if you hear no noise, that means he's totally obstructed, now you're going to have to help him. And this is when you go behind the patient and you make a fist with one hand and you point your thumb towards his abdomen just above the belly button. And then you wrap the other hand around the fist, and what you're going to do is you're going to pull in and you're going to pull up at the same time as hard as you can. See if you can dislodge that. So what I recommend you do, and this again is not in the book, what I recommend you do is put your leg between their legs, because if he passes out, which he probably will, then you're going to have to catch him before he collapses to the ground. And if I'm holding him this way, I've got to hold him with my arms. If I put my leg in between his legs, I catch him with my leg. It makes it a lot easier to lower him to the ground. So all I'm doing is, and one of two things is going to happen. Either he's going to spit the object out or he's going to pass out. When he passes out, I lay him on the ground. And the first thing I'm going to do is I'm going to check his mouth. Because, what did I say happens when we go unconscious? Our muscles relax, right? So if the muscles relax, that object may have made its way up to his throat. So I'm going to look in his mouth and see if I see the object. I'm never going to go in there blindly and see if I can find it, because I might push it back down in again. So I look in his mouth, I don't see the object, so the next thing I do is good old CPR. How many compressions? 30. How deep? 2. How fast? 120. How many breaths? 2. So now, before I give him a breath, I want to look and see, because maybe my compressions force that object up to his mouth. So I'm going to open his mouth and look and see if I see it. I don't see it. So now I'm going to try to put 2 breaths in. Oh, it didn't go in. Maybe I don't have his head tipped back far enough. So let's retilt his head. It still doesn't go in, so he's still blocked up. So I'd go back to more compressions, look in his mouth. Oh, there it is. So now I can take it out of there. And chances are he'll probably start breathing right away. So that's an adult. When did I hit him on the back?
After he passed out.
Did I? Did I ever hit him on the back? What happens if I hit? Aren't we supposed to hit them on the back when they're choking? Don't I do that? No. Why not? Yeah, if I loosen it up, it's only going to go down, right? So it might lodge deeper in his esophagus. So I never want to hit him on the back. But when I have a child or an infant, a smaller patient, I can hit him on the back. And here's the reason why. First of all, when we go on when we stop breathing, we start becoming what's called hypoxic, and our skin starts to turn blue, our nail beds start turning blue, our lips start turning blue. It's lack of oxygen. And so infants are just like that, only their whole body starts to turn blue. They're very oxygen dependent. And so when we have an infant, they're similar to an adult, except his whole body starts turning blue, and his eyes are bugged out because he's panicking, and he's gasping for air, so his mouth is open. But here's what the difference. Because they're this size, I can support his head and put him on my forearm, and I can get his head below his body. And now I can take the heel of my hand and I can hit him across the shoulder blades pretty forcefully. 5 times. Then what I do is I flip him over to the other arm so he's now face up. And I look in his mouth. I don't see that object. So now I'm going to do chest compressions. But how do I do chest compressions on an infant? 2 fingers, right on the nipple line. So I do 1, 2, 3, 4, 5. I look in his mouth again. I don't see the object. So I flip him back to the other arm, head below his body. 1, 2, 3, 4, 5. Back to this arm, face up. I look in his mouth. There's that object. Throw that away, and by this time he's probably yelling. And that's a great sound to listen to, okay? First week on the job in the fire department, 1 block away from the firehouse, raining cats and dogs, and the call came in, baby not breathing. We raced down there, and I started to get out of the ambulance. Mom come running off the front porch with the baby, and she said, "He stopped breathing." And you missed him, yeah. I was a football player. And she handed the baby to me, and I was able to take him in my arm, and I looked. I didn't see anything object in his mouth. So I started right here, just out in the rain, and he immediately started crying. Nothing came out of his mouth, but we went back in the house, and I said, "Mom, what happened?" She said, "Well, he has a 2-year-old brother, and he was on the couch, and the baby was on the floor next to the couch, and the baby brother jumped off on top of him and knocked the wind out of him." So he did not have anything lodged, but he had the air knocked out of him. But same result. As soon as he started crying, I said, "Thank you, Lord." The Heimlich maneuver works actually most of the time. Okay. Yeah, it's probably 3/4 successful. It doesn't take a whole lot to knock that out of people. If they get a little pressure build up on the inside and you push it, it'll pop right out in many cases. Most cases, as a matter of fact. Because I am about finished.
Thank you very
So,
much.
well, appreciate doing it. So I enjoy doing this. So thank you.